Hello students, I am Dr. Amit Kumar Adya, and in this lecture I shall talk about the practical aspects of the female and male genital tract. Please note that the theory classes have been uploaded separately and you can visit the same. In this lecture I shall cover some of the important diseases of the female and male genital tract. These are the ones which are commonly asked in the practical exam. As you know, the uterine cavity or the female genital tract is composed of the fallopian tubes, the uterus and the cervix, and the tubes are attached to the ovary. Here in this discussion we shall talk about some of the pathologies of the endometrium, pathology of the myometrium, that is Leiomyoma and Leiomyosarcoma, pathology of the cervix, mostly when concentrate on cervical cancer, and certain tumors of the ovary, that is Serous cystadenoma, Mucinous cystadenoma and the Dermoid cyst. In addition, I shall be talking about the Hydatidiform mole which occurs frequently within the endometrial cavity. We shall also discuss about the nodular hyperplasia of prostate and testicular seminoma as an example of testicular tumor. Endometrial biopsies are very commonly done and received in the pathology department for diagnostic purposes. They are mostly done for dysfunctional uterine bleeding or abnormal uterine bleeding. They are usually received in small fragments. If you look at the normal histology of endometrium, you will find that the endometrial cavity is lined by an epithelium. This is a single layered epithelium, usually tall columnar type. This epithelium dips down into glands. The shape and structure of the glands vary with the phase of the endometrium. In the proliferative endometrium, the shape of the glands is tubular, as shown in this picture. The same surface epithelium continues into the glandular epithelium. Hence, the glandular epithelium is also tall columnar type. So, if a biopsy is taken, it depends how the biopsy is cut. If the biopsy is cut transversely, then you see glands like this with a circular shaped glands with a lumen at the center. If the biopsy is cut longitudinally, then you will see elongated glands like this. There is some variation in the appearance according to the phase of the endometrium. Let us talk about the changes. The proliferative endometrium. It is from the day 1 of the menstrual cycle up to day 14 of the menstrual cycle is known as the proliferative endometrium. And the changes that you see in the endometrium are usually due to the influence of estrogen. As you can see in this picture, the endometrium is composed of glands and the stroma. There are two components, the glands and the stroma. The glands are cut transversely and you see the circular appearance. These are the tubular glands which have been cut transversely. So you see these glands, the shape of this gland is round. They have a lumen at the center and the cells are lined by tall columnar type of epithelium. If you see carefully, you will see that the nuclei are elongated like this and they are at different levels. That means they are not aligned at the same level. So this is what is known as a pseudo stratified nuclei. If you look at this gland particularly or this, you will see that the nuclei are pseudo stratified. And because this is a proliferative phase, the glands are proliferating, that means they are undergoing cell division. So you will see mitosis. You will see mitotic cells in the epithelium. You do not see mitotic cells in the normal secretory endometrium. If you pay attention to the stroma is usually composed of spindle cells because they are mesenchymal cells. So the spindle cells are like this. They have an elongated nucleus, and if you see the stroma, it is very compact. That means the cells are very tightly packed with each other. This is a feature of the proliferative endometrium. In the secretory endometrium, you will see a loose and edematous stroma, and the stroma is very cellular also. So these are the features by which you can identify the proliferative phase of the endometrium. In contrast, if you look at a secretory endometrium, you will note that the structure or shape of the glands have become now tortuous. They have become like this, sometimes referred to as corkscrew-like appearance. All these changes occur in the endometrium under the influence of progesterone. If you see, the stroma now starts looking a bit pale and more pink as compared to the proliferative endometrium, where the stroma is very blue appearing. So you find tortuous glands. The nuclei, they now align themselves in a single row, as you can see here. Unlike the pseudostratification that you see in proliferative endometrium, the nuclei here are in a single row. Vacuoles appear within the epithelium. Initially, in the secretory phase is usually divided into three: the early, mid and late. In the early secretory phase, you will see the vacuoles appear beneath the nucleus. As you can see in this picture, the nuclei are towards the lumen. This is the lumen. Nuclei are towards the lumen, and vacuoles are present beneath the nucleus. Hence the name subnuclear vacuolations. As the phase progresses, these vacuoles, they go above the nucleus and become supranuclear. And finally, in the later stages, the vacuoles get secreted into the lumen as secretions. At that stage, the glandular epithelium becomes very low cuboidal type, becomes small, changes from tall columnar to cuboidal, because all its secretions are now within the lumen. That happens in the late phases of the mid secretory endometrium. As the phase progresses into the late stage, you mostly see stromal changes. These are the three stromal changes that you will see in the secretory endometrium. It is characterized by stromal edema that gives rise to this looseness of the stroma, appearance of spiral arterioles, and stromal decidualization. These are the three pictures of late stage of secretory endometrium. As you can see, the stroma shows arterioles. As these arterioles are spiral like this, they are not straight. So when you cut through them, you get these arterioles at multiple levels. This is what has happened here. You are seeing the arterioles at 3 or 4 different levels, and that is how we identified that these are not straight arteries, rather they are spiral arterioles. In addition, if you look at the stroma, it appears very loose and edematous. Edematous because under the influence of progesterone, fluid tends to accumulate within the stroma. So stroma becomes edematous, and as you progress through the phase of the secretory endometrium, you will find that the stroma has now become more epithelial type. The stroma, being mesenchyme, is usually spindle in shape, like this, as you have seen in proliferative endometrium and even in secretory endometrium early phases. But gradually, under the influence of progesterone, the cells become more polygonal, have a centrally placed nucleus, and abundant eosinophilic cytoplasm that you can see here. And the normal glands of the endometrium now have become very small because all their secretions have been thrown into the lumen. So this is known as decidualized endometrium, and this thing is known as decidua. Right? So in the exam you are expected to identify the given slide as endometrial tissue, and then to distinguish between proliferative and the secretory endometrium. Here I enumerate some of the differences again for you. In proliferative endometrium, the glands are tubular, nuclei are pseudostratified, cells are tall columnar, and the stroma is very compact, appears blue under the microscope. Whereas in the secretory endometrium, the glands are tortuous or corkscrew shaped. You will find subnuclear vacuolations. You will find secretions in the lumen. The stroma will show you edema, the arterioles, spiral arterioles, and the decidualization. Right? So these are the differences. Let us move on to some other pathology of the endometrium. The second most common thing that you will be shown is the endometrial carcinoma. If you look at this picture, this is a cut open uterus. This is the cervix. If you see, this is the myometrium here. This is the endometrial cavity. But the endometrial cavity is not empty. You see, there is a big growth or a tumor in the endometrial cavity, totally filling up the endometrial cavity. This tumor is usually very friable, necrotic, and hemorrhagic. So it gives rise to abnormal bleeding, uterine bleeding. The most common symptom of endometrial carcinoma would be an abnormal uterine bleeding. And as you know from our theory discussion, that endometrial carcinomas can be type 1 and type 2. I am not going into the details of the same. The most common type that you will see is the type 1 carcinoma, also known as the endometrioid type of carcinoma. The slide of this case will show you these features. So basically what we usually do is take a section like this. So this will include the myometrium and the endometrium. So this part is the myometrium and this part is the endometrium, which is showing you the tumor. If you see, this tumor is showing you papillae like structures like this. Some are branched, some are not, but these are papillae. Endometrioid carcinomas are usually papillary adenocarcinomas. This is in the higher power because these papillae are very complex. They are not simple papillae. Two adjacent papillae will be joining with each other and forming very complex arborizing structure. So when you cut through them, you will have an appearance somewhat like this. You can see the papillae. Papillae usually have a core. The core is the supporting stroma of the papilla, and the core is usually fibrovascular. That means it consists of fibrous tissue and blood vessels. So fibrovascular core, papillary architecture, a very complex papillary type arrangement. Sometimes you see glands, and the glands have a back to back arrangement. That means the glands are very close to each other. Unlike in proliferative endometrium, if you go back to that picture and see, there is a lot of stroma between two adjacent glands. This is not the case in carcinoma. Stroma is very little and the glands are very closely packed to each other. That is known as the back to back arrangement of the glands. The glands will show you nuclear atypia. When I say atypia, that means I am talking about the nuclear feature or anaplasia. That is, if you if this is the cell, tumor cell, and this is a normal cell will look like this, and the tumor cell will look like this. The changes that you are seeing in the nucleus of a tumor cell is what is known as nuclear atypia or anaplasia. If I put these changes into words, then I will say that there is a large nucleus, irregular nucleus, prominent nucleoli, hyperchromatic or dark nucleus, high nucleus to cytoplasmic ratio, and pleomorphism. Some cells will be large, some will be small. They will have a very bizarre kind of appearance. So pleomorphism, hyperchromasia, high NC ratio, nuclear irregularity, prominence of nucleoli are the features that characterize nuclear atypia. In addition, the hallmark of malignancy, that is invasion, will be there in all carcinomas. So this tumor, as you see here, is invading into the underlying stroma or the endometrial stroma. It can invade through the myometrium and also go to different places of the body via metastasis. So this is a papillary type of adenocarcinoma, otherwise called as endometrioid adenocarcinoma. Next thing that we will learn are leiomyoma. Leiomyoma are the benign tumor of the smooth muscle. Myo refers to muscle, oma tells you that this is a benign tumor, and leiomyoma means a smooth muscle. Leo means smooth. If it is a tumor of the skeletal muscle, it will be known as a rhabdomyoma, right? Because those are striated muscles. Similarly, the heart also contains muscle. If a tumor arises from the heart muscle, it will also be known as rhabdomyoma because they are also striated muscles. And if a malignant tumor arises from the smooth muscle, then it will be known as Leiomyosarcoma. Instead of oma, you will have to use sarcoma there, right? That is the nomenclature. You already know about it. Now, leiomyomas can occur anywhere in the uterus, or they can also occur outside the uterus. Also, they can occur, in fact, they can occur anywhere in the body, wherever there is smooth muscle. Can you think of some area in the body where you do not have smooth muscle? Yeah, I think you guessed it right. It's not inside the brain, but everywhere else, wherever you have blood vessels have smooth muscle in their wall, so they can have a smooth muscle tumor. So leiomyoma is a universal tumor. It can occur anywhere, not only in the uterus, but they are frequent in the uterus. Now, according to the location, grossly they can be classified as submucosal if they are just beneath the mucosa, or intramural if they are totally within the myometrium, or they can be just beneath the serosa. They will be known as subserosal. Sometimes they are attached to the uterus with the help of a pedicle, and this is known as pedunculated leiomyoma. Now, these are the leiomyomas which can undergo torsion and hemorrhagic infarction. Sometimes this pedunculated leiomyoma, they protrude through the vagina and mimic a vaginal or cervical growth. Leiomyomas can also occur in the fallopian tube, in the ovary, in the peritoneum, everywhere. And this is exactly the gross picture of the mounted specimen that we have in our museum. You see there are large fibroids. Leiomyomas are also known as fibroids. So leiomyomas can be single, they can be multiple, they can be of very small size like 1 centimeter, or they can grow up to very huge size. They can go up to 30-40 centimeters because they are benign tumors. So they can grow up to a large size without causing any symptoms. And this is the gross picture of a uterus, and you see there are multiple leiomyomas. Some are subserosal, some are intramural, some are intramucosal, right? So variety of leiomyomas are there in this specimen. Another thing you note that when we have sliced this specimen, the leiomyomas have started protruding out. They have popped out of the cut surface. The popping out is basically due to the fact that these benign tumors, they have a very well defined cut surface and they are under constant pressure within a capsule. So when we cut it, they pop out. So popping out is actually a sign of benign tumor. Malignant tumors, they usually infiltrate into the adjacent tissue, and they have a lot of fibrosis and desmoplasia. So when we cut the tumor, they usually retract back. So retraction is a feature of malignant tumor and popping out is a feature of benign tumor. If you look at the microscopy, you will see that these tumors are composed of fascicles or bundles of fibers. The bundles go like this. Some bundles are like this in this picture, some are like this, some are going like this, some are going like this, like this. See here, like this, like this. So they are usually interlacing fascicles or bundles of smooth muscle cells. If you see them in high power, you will notice that these cells have a nucleus like this. This is known as a cigar shaped nucleus. This nucleus is like this because it is elongated and the ends of the nuclei, they are blunt and it looks like a cigar. In contrast, a tumor arising from the fibrous tissue will have a pointy end like this. Fibrous cells nuclei are usually pointed ends. Similarly, a nerve tumor that we will see in another lecture, you will see that they are pointy and sometimes the nuclei are like this, wavy in nerve fibers. But the diagnostic hallmark of a smooth muscle cell is the cigar shaped nucleus. You see here, this is known as cigar shaped nucleus. They have abundant pink cytoplasm, that's why this tumor is appearing pink. This is all cytoplasm of the cells. The borders of the cells are indistinct, so you are unable to see them. It feels as if the nuclei are floating within a pink background. That's because the border of the cells are not distinct. And there is no nuclear atypia. This is important because if nuclear atypia is present, you can no longer call it a smooth muscle tumor, benign smooth muscle tumor. Then you have to call it Leiomyosarcoma, which we will see in the next slide. So Leiomyosarcoma, the malignant tumors of the smooth muscle. Here the architecture of the cells will be similar. As you can see, the long bundles of smooth muscle, some are going like this, some are like this, some are like this, some are like this. So these are interlacing fascicles of bundles of smooth muscle, and at higher power they maintain their cigar shaped nuclei and abundant pink cytoplasm. That is how we recognize them as smooth muscle. And if you see at a still higher power or in other areas, you will see that there are large areas of necrosis. This area is necrosis. The cells can be easily seen here, the nuclei, you can appreciate the nuclei, but in this area you see, feels as if there are some pink granular material and there are blue dots within them. These blue dots are basically the fragmented or karyorectic and karyolytic nuclei of the tumor cells. So the presence of this nuclear fragmentation and fragmentation of the cell tells you that this area is necrosis. So Leiomyosarcoma will show you feature similar to a leiomyoma in that they have bundles of spindle cells, cigar-shaped nucleus, abundant pink cytoplasm. But then what will distinguish a sarcoma from a benign tumor are nuclear features of malignancy, that is the hypercellularity, nuclear pleomorphism, presence of mitosis, necrosis, and of course invasion and metastasis, right? So this is leiomyoma and leiomyosarcoma. Another commonly shown specimen in the practical and in the museum classes is the carcinoma of the cervix and its slides. If you look at this specimen, this is again a cut open uterus. This is the cervix portion, the endometrial cavity, and the myometrium. There is a small leiomyoma here. Leiomyomas are many times incidental findings, that is they do not cause any symptoms, so they go undetected, and they are incidentally detected when uterus is removed for some other cause. Here in this patient the uterus was removed for cancer of the cervix. As you can see, the cervix has a big growth. This growth is hemorrhagic, necrotic, and friable. Carcinoma cervix usually grows as a cauliflower like growth and protrudes into the vaginal canal. The size can range from 0.5 centimeters to about 5 centimeter in size of this tumor, and most common symptom they produce is abnormal vaginal bleeding. Carcinoma cervix has a precursor lesion. You already know about it from the theory lectures. Those are known as squamous intraepithelial lesion, which are of two types, the low grade and the high grade, H-cell and L-cell. Here in this picture I have shown you the squamous epithelium, and the squamous epithelium shows presence of complete full thickness dysplasia, so this will qualify for a high grade cell. Usually cells are not given in the exam, but this is just for a demonstration purpose. You will find a slide of carcinoma cervix though. Carcinoma cervix is easy to identify because most of them are usually squamous cell carcinoma, and squamous cell carcinomas are identified by 2 or 3 very important features, which is the presence of the keratin pearl, because squamous cell carcinoma is the only carcinoma which can produce keratin pearl. So if you see under the microscope, the pearls are usually arranged like this, keratin, and they are surrounded by malignant squamous cells as shown in this picture, and the squamous cells show nuclear atypia. So when I say nuclear atypia, you know I am talking about nuclear pleomorphism, enlargement, irregularity, nucleoli, etc. Another important feature of this squamous cell carcinoma is that cells show intercellular bridges, as you can see here in this picture. So between two squamous cells there are usually bridges like this. It is all around, by which it is connected to its adjacent squamous cells. These are the bridges that hold the squamous cells together. They are usually hemidesmosomes. So when these bridges are lost, like that happens in cancers, these bridges are lost and the cells become free to move around, and they move into the blood vessel and go to distant sites and cause metastasis. So these intercellular bridges is a very peculiar feature unique to the squamous cell carcinoma and the squamous epithelium. These bridges are normally present in the squamous epithelium, and when the tumor becomes very malignant and metastatic, these bridges are lost. And most importantly, invasion, as any carcinoma is distinguished from a non-carcinoma or a pre-malignant in situ lesion by the presence or absence of invasion. So invasion will be seen. So these are the identifying features of a squamous cell carcinoma of the cervix. Another common specimen that you will be shown are the ovarian tumors, the ovarian serous tumor and mucinous tumor and the teratoma. Here this is a gross picture which shows the ovary is massively enlarged into a large cyst-like structure. The outer surface is very smooth, and when you cut it, this is the cut appearance. The inner surface is usually also smooth. These tumors can be uniloculated or they can be multiloculated. Loculations refer to the number of cysts present within the tumor. Like here there are 3 cysts or maybe 4. So this is a multiloculated cyst, and this individual cysts are separated from each other by thin septae. And the serous tumors usually contain a very thin watery type of fluid inside the cyst lumen, whereas the mucinous tumors, they will contain a thick mucoid like gelatinous material within the lumen. That is how grossly serous cysts and mucinous cysts are distinguished from each other. Now since this is a benign tumor, you won't find much of features of malignancy. The features of malignancy on gross are irregular outer surface, solid areas rather than cystic, presence of lot of complex papillae, friable growth and invasion, and presence of hemorrhage and necrosis. So because all these things are absent in this tumor, we can safely call this tumor as a benign serous cyst adenoma of the ovary. Under the microscope, this is the cyst lumen, and the cyst will be lined by an epithelium which will resemble the epithelium of a fallopian tube. There will be a single layer of epithelium. These are the fallopian tubal epithelium is usually tall, columnar with some pseudostratification and presence of cilia on the surface. So this is a ciliated, pseudostratified, tall columnar type of epithelium which characterizes the fallopian tube epithelium and the serous tumors. And you will not find any evidence of malignancy. By evidence of malignancy under the microscope, I mean there will be no invasion or no metastasis, or there will be no nuclear atypia, that is hyperchromasia, pleomorphism, provenance of nucleoli, mitosis. I keep repeating these things so that it gets imprinted into your mind. So this is benign serous cyst adenoma of the ovary. The only difference between the benign cyst adenoma, serous adenoma and mucinous cyst adenoma is the lining epithelium that you will see in mucinous cyst adenoma. The lining epithelium resembles the endocervical type or the gastric type or the colonic type of mucus secreting epithelium. If you see, the nuclei are present at the bottom in a single row, and there is a lot of mucin. This pale appearance, vacuolated and pale appearance, means the cells contain a lot of mucin. So this is a mucinous type of epithelium which you will see in the mucinous cyst adenoma. And because this is adenoma, that is benign, so you won't find any features of malignancy as discussed for serous. The dermoid cyst. As you know from our discussion of the theory of ovarian tumors, that teratomas can be classified into mature and immature, and mature teratomas can be cystic and solid, and usually the cystic mature teratomas or the benign mature teratomas are known as dermoid cyst. As you see in this picture, this is the uterus, and this is the ovary. The ovary has been sliced, cut open, so that you can see the lumen. So you can say that this is a uniloculated cyst, and the inner wall of the cyst is very smooth appearing, and there are these some solid and protuberant areas, and if you see carefully there are a lot of hairs arising from these protruded areas. This because this is a museum mounted specimen, the contents of the cyst have been removed. Otherwise, usually the cysts contain a lot of cheesy material, because the cysts are usually lined by a squamous epithelium, and the squamous epithelium produces keratin. So keratin gets deposited within the lumen and appears as a cheesy, necrotic, foul smelling material. In addition to all this, you can also sometimes find teeth and bone and well formed organs such as eyeballs. You can find half formed uterus or brain or kidney or anything within this tumor. And this is the usual microscopic slide that is provided to you. So if you take a section like this from the cyst, it will show you this picture. This is the lumen and this is the outside. There is lining epithelium which is squamous type, we will see in higher power, and the cyst is usually filled with a lot of keratin. The pink dirty appearing thing in the background is keratin. Let us go to the high power. Yeah, this is the high power. You can see that this epithelium is stratified squamous epithelium, and it shows you a lot of sebaceous glands, the same type of sebaceous gland that you find in the skin, in the scalp and other areas of the body. And the lumen contains this flaky like substances, flakes known as the keratin flakes. These are other areas of the same tumor. You can appreciate the squamous epithelium better here, the stratified squamous epithelium having a basal row of melanin containing cells. This is the lumen, and the surface contains these granular cells, and the 4 or 5 layers of the squamous epithelium are evident. In addition, you see hair follicles, because this tumor can contain a lot of hair. The hair follicles are arising from the, so this is basically a skin like epithelium where you find the epidermis and the dermal appendages. Those are the sebaceous glands, sweat ducts, eccrine glands, hair follicles and everything. They represent the epithelial component of the dermoid cyst. As you know, teratomas can produce epithelial or otherwise known as the ectodermal tissue. They can produce endodermal tissue, they can produce mesodermal tissue. As in this picture, you see cartilage, mature cartilage, and a respiratory epithelium which is derived from the endoderm. The cartilage is a mesodermal derivative. The skin and sometimes you can see brain inside the teratoma, those are ectodermal in origin. In addition to cartilage, there is fat in this picture. Fat, tooth and bone can also arise from the mesodermal component. So a teratoma is characterized by usually a cyst which is filled with hair, cheesy material, bone, tooth, and they show derivatives of all the 3 germ cell layers. For a more detailed discussion on teratomas, please refer to the theory lecture uploaded at the site. One more thing that we shall discuss in the female genital tract is the Hydatidiform mole. You might be aware that Hydatidiform mole arise during or after pregnancy. They are due to abnormal fertilization of the ovum and the sperm. I am not going to discuss the details of the theory part. The Hydatidiform mole can be of different types. As you can see, sometimes it fills up the whole uterus. This occurs during pregnancy or after pregnancy. Sometimes it is associated with a fetus. The H mole is present alongside a fetus, which is usually dead or can be alive sometimes. So when this happens, there is no fetus and only H mole. It is known as a complete hydatidiform mole. When it occurs with fetus, it is known as a partial hydatidiform mole. Sometimes this hydatidiform mole can invade and destroy the uterine wall. Then it is known as an invasive mole. It is only locally invasive. Sometimes the tumor arising from the trophoblast. Usually hydatidiform mole are tumors of the trophoblasts. Trophoblasts are the cell which are derived from fusion of the germ cells. Sometimes the tumors are malignant and they are known as choriocarcinomas. These malignant tumors can rapidly metastasize to different sites of the body, most common being the lungs. You shall be shown the complete hydatidiform mole only, not the rest, because that is the most common type. This is one of our museum mounted specimen. The uterus was not removed in this case, only the contents of the uterus was removed. Hence what you see here are a bunch of grape like structures. The hydatidiform mole are usually swollen up or hydropic degeneration of the chorionic villi. When they swell up, they appear like grapes, grape like structure. They are thin walled vesicles, and when you cut them, they will contain thin fluidy material. Under the microscope, these are those grape like structures which have been cut. These are actually the chorionic villi, which are swollen up and show hydropic degeneration. At the center of this villi, they usually show empty fluid containing spaces known as the cistern like spaces. And this chorionic villi will show you proliferation of the trophoblastic cell all around them. This is known as trophoblastic proliferation. As you can see in the higher magnification, this is the chorionic villi. There is no blood vessel inside the chorionic villi. Normally the chorionic villi contains a lot of blood vessels because it is the site where there is transport of materials from the maternal to the fetal circulation. But these chorionic villi, they do not contain any blood vessels, so they are known as avascular hydropic degeneration of the chorionic villi. The chorionic villi, as you see, there is a lot of cells which are proliferating around the chorionic villi. These are the intermediate type of trophoblast. There are three type of trophoblasts: the cytotrophoblast, in situ trophoblast, and intermediate. In situ means the trophoblast, single trophoblast will have multiple nuclei because many trophoblastic cells have joined together to form a syncytium like appearance. So this is the in situ trophoblast. Cytotrophoblast are these cells which are single layered and mononucleated. They are known as cytotrophoblast. And then the cells which are in between the two are known as the intermediate trophoblast, as you see here. So there is a marked proliferation of the intermediate trophoblast in these mole like situations. So these are the features of hydatidiform mole. One more thing that is usually asked is what is the ultrasonogram features of this hydatidiform mole. It shows a snowstorm like appearance in the ultrasonogram, and moreover beta HCG is the serum marker for trophoblastic diseases. Next we'll look at two slides pertaining to the male genital system. The first of them is the nodular hyperplasia prostate. This has been discussed in detail in the theory lectures. Here you will be provided the slides and you are supposed to identify the parent tissue as well as the pathology. The parent tissue is identified as prostate here due to the presence of three things: presence of glands and stroma, and the stroma which contains both smooth muscle and fibrous tissue. These cells, the more pink appearing spindle cells, are the smooth muscle cells, and the paler acellular material in between is the fibrous stroma, and these are the glands. The glands usually have a double layered epithelium. If you see here, there are two layers, the inner epithelial and the outer basal. So this is the normal histology of a prostate. If you look at the slide of a nodular hyperplasia of prostate, you will find that there is marked proliferation of these glands which are forming nodule like structures. The nodules are there. At a higher power, you will find that these nodules are due to cystically dilated glands, and these glands, due to excess of cells, they are producing papillary infoldings and outpouchings. They are very closely arranged to each other, in contrast to the normal prostate where they are far away from each other. In addition, these glands show secretions within the lumen. These pink secretions are known as corpora amylacea. An important feature which distinguishes hyperplasia from malignancy is the intactness of the basal cell. In benign conditions, the basal cells are maintained, whereas in malignancy there is a loss of the basal cell layer. Apart from the glands, the stroma is also proliferating. Please remember here that actually the stroma is proliferating and the glands have increased in number because the epithelial cells are not dying. We had a detailed discussion on this in the theory lectures. Another important slide pertaining to the male genital system is the seminoma of testis. It is a germ cell tumor of the testis. Here I will only discuss the salient microscopic features which will help you to identify that this is seminoma. The tumor is composed of nests of cells, as you can see here. There are nests of cells which are separated from each other by this septae, and the septae contains numerous lymphocytes. This is the hallmark feature of seminoma, and please remember this is same as dysgerminoma of the ovary. So nests of tumor cells and the septae infiltrated by lymphocytes. If you look at individual cells, the cells are round, they are large, they have abundant clear cytoplasm. The emptiness around the nucleus is basically due to a clear cytoplasm. The cytoplasm is clear because it contains glycogen, which does not take up the stain. If you look at the nucleus is centrally placed, and the nucleus has got a centrally placed nucleolus. A large prominent centrally placed nucleolus is a characteristic feature of seminoma. So the seminoma of testis is identified by the presence of these large cells with clear cytoplasm, prominent nucleolus, and a centrally placed nucleus, and a lot of lymphoid infiltrate in the stroma. This lymphoid infiltrate is basically because of the fact that the germ cells are cryptic antigens. They are hidden from the immune system. So when the tumor occurs, the immune system recognizes them as foreign and mounts an immune response against them. So a lot of lymphocytes tend to infiltrate into the tumor. In addition, you can sometimes have granulomas, epithelial cell granulomas in and around the tumor. So that's all in our discussion of male and female genital system. These are the common slides that you will encounter, and I hope you have understood most of it. Thank you.